Okay, welcome to Spine Conference. Today's discussion is slightly esoteric, but I hope you're going to find it interesting. It's revision posterior cervical laminoplasty. So the format is, if anybody has any questions anytime, just interrupt and ask. Or if you're curious, this is for you all. And it's informal. 1 second. Okay, so I like case-based learning because just like in medical school, when you meet the patient who has the disease process, you never forget it. So the beginning here, I want to go sort of quickly because this case it's over the course of a couple years. So we're going to start from the very beginning. It's a 47-year-old woman with a 6-month history of neck stiffness and pain in her left upper extremity. She had paresthesias into her elbow, forearm, hand, especially her index finger and thumb. So here are some x-rays, and they just show this is no trick questions, but Charlie, just so we can go back and forth, just to make it a little fun. Like, what do you find on the x-rays just in general?
Well, let's see, 2, 3, 4, 5, 6, 7 different there appears to be some specific extension into the canal. That looks like
Yeah. So
5, 6,
a little bit there.
right. Yeah, see that.
Yeah. So he sees that right away. But usually, it's difficult to notice. Okay. Yeah. So she's not lordotic. She's a slightly kyphotic. She's 6 degrees. I measured it 6 degrees of kyphosis from C2 to C7. Normally, how much? 20 degrees? What do you think, Charlie? Lordosis, cervical spine, ballpark.
Right now?
No. What should you have as a normal person? How much does Christina have? She looks pretty lordotic. She's like 25. Yeah. Okay. So almost everybody comes to me with an MRI. So here's the sagittal MRI. What are your thoughts?
Well, thickened, darkened density.
Yeah.
Not water density.
Yeah.
Looks like cortical bone density.
Yeah. So thick and black.
Canal.
Posterior to the vertebral body. And the disc heights look totally pretty normal.
I think it also shows that the original canal AP diameter midline was approximately normal range. Typically the between body front to back diameter approximately the same as the canal. So it used to be that way. Of course,
Yeah. So here's just a couple more sagittal views. So I'm going to go through this sort of quickly because there's a lot of images to look. So here's a axial cut through C3, and you can see the black ossification of the posterior longitudinal ligament should not be there, and it's compressing the spinal cord. So that's C3. I'm kind of going fast, I know, but C3, C4, you see how the spinal cord, that's the spinal cord right there, that circle. It's flat and compressed. C4, C5, even a little worse. So here I measure the spinal cord in units. The ratio is 3 to 1. And this just gives you an idea of the shape of the spinal cord. It's just a basic shape. Just remember that in the back of your head. C4, C5, C5, C6, even a little flatter. C6, C7, small area for the spinal cord. At C7, T1, the ratio of the spinal cord is 2 to 1. So I usually use my rule of thumb. I don't know what you do, Charlie, but my rule of thumb is what's normal, what's not. Everyone's a little bit different. But the spinal cord should have a very, very similar shape all the way up and down. It gets a little bit thicker at C5, C6, say C4, C5, where you have a lot of activity of the nerve roots into the upper extremities. But in general, it should be a very similar shape. So that's what I use, what's normal. What are your thoughts? What do you use as normal?
I usually go to
Right. That's what I mean by that. Right. So the non-affected levels should be the person's normal shape and normal spinal canal for that matter. So I think this woman's normal should be about 2 to 1 for her. So you can see that her spinal cord is compressed. Now, is that a problem? So normally the spinal canal, you can see the top right, should have plenty of room for the spinal cord. And the spinal cord lives within the spinal canal. And there should be CSF all about the spinal cord. And here's just an example of a normal cervical spine. And you see how there's CSF all about the spinal cord. And on the axial cut, plenty of CSF about the spinal cord. Now, one of my favorite books. Did you ever get this book, Rene Louise, Surgery of the Spine? It's an 80s book. You have it? So it's one of my favorite books, and in it he has just a graph of a table of what's normal AP diameter and transverse diameters for the cervical spine, and you can see the average person should have about 14 millimeters, and the range is anywhere between 10 to 18. So I think the ballpark is like 10 millimeters is should be the minimum. Does that sound about right to you?
Yeah, I think it's pretty variable. I mean, I see people who have no disease yet, but they're not going to be back with their spectrum. Those people are really down in the developmental side.
And they're at risk for any kind of
Yeah,
problem.
they're any kind of
Yeah.
They could be at 10 or 11 years.
Mhm. So this is a 1963 graph this is a picture from a 1963 article in British Medical Journal about cervical stenosis and the progression of it. And the left side, I know this is boring, but the left side, the big black bars are progression of cervical stenosis over the course of 30 years. So if you see someone with cervical stenosis, it progresses, but it progresses slowly and in spurts. Um, so cervical stenosis almost always gets worse, but it gets worse over years and in spurts. So they get worse, 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 then they're kind of stable for a while, worse, 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 stable for a while. So signs of myelopathy. So if you have pressure on your spinal cord, you can develop myelopathy or problems with the spinal cord. I feel, my personal opinion is it's very difficult to diagnose myelopathy, and some people don't get myelopathy. Some people deteriorate very quickly, and when they have cervical stenosis, they fall off a cliff, and they become spastic. Their arms don't work. It's a serious problem very, very quickly. So I think as a surgeon, it's very difficult to understand the progression of the disease because it can be very quick. I mean, not to be an alarmist for people, but I think it's hard. I mean, what are your thoughts about that, cervical stenosis?
Yeah, I agree that it can be episodic, and some people really kind of even dismiss it. And I see people coming into it, have pretty alarming findings. It seems to be to me that there's a room for those patients who really don't know when they get worse, and they're like in denial. I see a lot of people who don't go to doctors, and then they're just on a first examination. They say, "Well, this person acts well," but other times you see people who have a lot of complaints, and you don't see much of anything on their examination. On an MRI, you might even see some tissue uptake in the cord where the cord is fairly complete. So it has an amazing variation of presentation.
Okay, so just some signs are inverted of myelopathy are inverted supinator reflex. So you strike the brachioradialis and it goes the opposite direction it should go. Lermite sign, if you push on someone's head, they get radiculopathy type symptoms in their arms, pain, burning, etc. I've seen all of these. Finger escape sign, people just say they just come in and they don't even realize their fifth and fourth finger are weak. They have intrinsic weakness of their hands, and they just don't even know why. Then they just blow it off as I'm just getting older. Um, uh, I practice this word, dysdiadochokinesia, or grip and release sign, which is when you do your hand very quickly. People with myelopathy can't do that. Either you can do either supinate, pronate, or grip and release. Other signs are Hoffman's sign, flexing the DIP, makes your thumb and index finger flex. Does anybody want to add any other signs or symptoms?
Hip flexion
Puffins. Mm-hmm.
It's just flipping your finger like that, and having your whole thumb involuntary contraction.
So what level of spinal cord compression is a problem? So this is an article from Spine 1983 where, remember I said the ratio, that woman, the 47-year-old woman, was 3-to-1. If it gets down to 5-to-1 or 1-to-5, this causes cord compression, ischemia, and direct mechanical trauma. So 5-to-1 ratio flattening the spinal cord is absolute indication that there's serious pressure on the spinal cord. So gray matter is like the cell bodies, and am I getting that backwards? No, cell bodies, and the white matter are the axons. So they're more sensitive. So a nerve root, which is all white, axons, can take a lot of pressure before there's a problem. But if you hit the cell body, it's a serious problem, like in the brain. Okay, so the typical stenosis comes from osteophytes, either the uncus or the end plate, into the spinal canal. So I want to show OPLL. How does OPLL progress? OPLL, which this woman has, is ossification of the posterior longitudinal ligament. So the posterior longitudinal ligament goes up and down the back of the vertebral bodies, and it's a ligament that just restrains the vertebral bodies, just like the anterior longitudinal ligament. So this is an axial cut through the cervical spine. You can see in the middle of the canal there's the spinal cord. So there's the posterior longitudinal ligament. You see it there, and what's yellow is the spinal cord. So you can just imagine that you have this disease process where the ligament has some type of osteoblastic activity. I'm not sure why, but it grows. And as it grows, it pushes on the spinal cord. You can see that. And then it eventually flattens the spinal cord. And like we said, it's a problem if the spinal cord is flat. It causes direct trauma and pressure on the spinal cord. It can lead to damage. So laminoplasty is basically a procedure, one procedure. I mean, there's different ways you can do it, but one procedure, laminoplasty, where on one side you cut halfway through the lamina. You see on the right, you cut halfway. And on the other side, you go all the way through. And then you green stick it. You basically bend one side and open the other side. And when you do that, the spinal cord has more room. But once you do that, you have to keep it open somehow because it'll flop right back down. And there's different options. I just drew there a plate. But there's different options to do that. So just so you guys, if you don't know what a green stick fracture, as an orthopedic surgeon, we know what green stick is. It means one side's broken and the other one's just bent. And these are examples of children with green stick fractures where one side of the bone breaks, the other half just bends. And that's what you do to the cervical spine. And it just comes from trees, like a young sapling. One side breaks, the other one doesn't, and the thing just bends. So that's laminoplasty. Laminoplasty originated in China. I mean, in Egypt. Japan. I got China on the mind because my children showed me this video of Donald Trump saying China like 100 times. So I just have China on the mind. So laminoplasty originated in Japan, and the first description was in 1973, where it was sort of a variant of laminectomy, where he thinned it down and just opened it up in a Z manner. And the reason why it started in Japan is they have a serious problem of OPLL in Japan, ossification of the posterior longitudinal ligament. The incidence in Japan is around 2 to 4%, and normally in like most populations is like 0.1%. OPLL, ossification of the posterior longitudinal ligament, is most common in the 5th and 6th decade. 3% of the patients are in cervical and less than 1 in thoracic, so it's much more common in cervical. Usually guys get it, 2 to 1 male to female. There's a genetic predisposition. If you have 60% of the spinal canal involved, you will become myelopathic. And the other very important fact is younger people progress. So if you're like our patients, in this case, is 47. Anybody younger than me is young. So 47 is a young person to get OPLL. And the other thing is it will probably progress. Like the OPLL will get larger. Okay, so any questions so far about OPLL? No? Okay, so this patient, just because she recurred, but I'll tell you what I did initially. 2.5 years ago, I did a cervical laminoplasty and applied plates C3, C5, C6. You can see my drawing on the top left. And I did a foraminotomy left C5, C6. for her symptoms. And I felt I wanted to open her spinal canal because she's this young person with stenosis, and she's a very vibrant person too, and she wanted it fixed. So I opened it for her, and she did absolutely perfect, totally asymptomatic. So is this a home run? End of story, you think? That's not the end, so she recurred, obviously. So just laminoplasty, just one more time, is top left, you expose the muscles, then one side you cut half, the other way, open it up and put a plate. And I also did a frame anatomy. This is just a cartoon of frame anatomy, is the junction of the lateral mass and the lamina. You drill a hole all the way down. The inferior facet you go through very quickly, then the superior facet you go slowly because under it's the dura, and then you peel the very last remnant of the dura, and you can see the nerve root there, and there's always a vein there too that can bleed sometimes. You have to either control it or just be wary. I try to be wary of it and not injure it. But with the new microscopes now, you can avoid these things. Now I usually use a Medtronic centerpiece laminoplasty plate. This is what it looks like. The top part goes against the lamina. The bottom part is a screw that goes into the lateral mass, and that little hook on the bottom hooks onto the lateral mass to keep it still before the screws go in. But you can use any plates you want. These are just some examples from Globus, from Stryker, a company called C-Spine, other companies. I guess the only reason I use Medtronic is that's the first one I ever used, and I'm just used to it. But there's a lot of different options. So when can you do laminoplasty versus when do you do corpectomy? That's the question. And the K line is something that can help you. If you draw a line from the middle of the spinal canal from C2 and the middle of the spinal canal from C7, if the OPLL is in front of that, is anterior to that, the spinal cord should be able to drape backwards, and you can do this safely from a posterior approach. But otherwise, you probably have to go through an anterior approach. So that's just the K line. So the line between the in the canal. The other time you cannot do a kyphoplasty is if there's kyphosis. If there's kyphosis, the spinal cord is draped on that thing. So no matter how much you open it up, it doesn't help because of the deformity. The OPLL is just sticking into the spinal cord. So you have to go through an anterior approach and remove it. The problem is going through an anterior approach in OPLL is dangerous. First of all, you're pushing into the spinal cord. You're indirectly decompressing it, and also you can get a spinal fluid leak. So once you apply the plate, that's what it looks like. You can see the laminas are hinged open. The plates are applied, and there's a lot more room for the spinal cord. The spinal cord drapes back. And so benefits of the laminoplasty is you avoid post-op kyphosis. If you could do a laminectomy, you can get post-operative kyphosis. You retain your motion, which I think is a good thing. Unlike a fusion, you never move again. The dura is covered, unlike a laminectomy. So the muscles, I think, attach back to the bones, and so you don't get postoperative kyphosis. And the laminas and the cervical spine is relatively normal appearing. So here's the patient post-op. She was a little bit kyphotic. And here's the post-op. You can see on the left, I burred halfway down, opened up the spinal canal. And you can see the plates opened up. You see how I cut on the left halfway through, and there's just like a little remnant of bone open. So this is all important because I'm going to show you different images later. You see how most of the lamina is removed. There's just a little bit of bone left. Okay, so post-operatively, I got an MRI because she was having some unusual symptoms. I wanted to make sure she was okay. You can see the spinal cord's got plenty of room now. And there is a sliver of CSF, both anterior and posterior to the cord. And here's the CAT scan, which just shows there's more area for the spinal cord. And you can just see here, top left is pre-op at C4, and bottom left is post-op. And you can see now the spinal cord's got plenty of room from the laminoplasty. And you can see the corresponding CAT scan, which I found is interesting. So this kind of like just explains how laminoplasty works, and you can see a case that it worked very, very well. And then post-op 6 weeks out, she was 100% fine. So any questions so far about laminoplasty?
Do they have a little bit of rotation, like limitation afterwards?
Yeah. Well, long testing, it doesn't seem to get as kyphotic, but they do tell more. They lose some of the cases. And I know some people basically put people in the grave for an extended period of time.
Morning, Dr. Allen. Yeah,
Good
you want you yeah, would you put him in? I don't do anything because
Yeah, I don't know, you know, it kind of defeats the purpose of doing the break sometimes. And some people kind of don't take a look on the hing side. Some people start with it on the broomstick side, and it'll fuse in that
okay, so let's keep going. So this woman, she did great, but there's nothing worse than for results than long-term follow-up. 2.5 years, right? She did fantastic, and she's actually a very wonderful woman. She came back, and she says, it's back. So now she's 49, 2.5 years later. That's not her, but that she kind of looks like that. She's left posterior arm pain, like triceps, left trapezial pain, left neck pain, left index finger pain. So she's 2.5 years out, and that's just her past medical history. She's pretty healthy, just high blood pressure. She has 4 children. Um, and this is her MRI now. And 2.5 years later. So Charlie, look at C2, C3. What do you see?
well, it's substantially more
Yeah.
progressed up the track.
Yeah, see that? Which was not
Yeah.
present last time.
Yeah.
And you can even see, if you look carefully, you can see that OPLL is a white density right there. So if you look carefully, you can see that on the, and then the CAT scan now, look at C2, C3, look how much bone is formed there. And now she's got a long sessile, continuous OPLL up and down the spinal canal. And the other thing I think is just real interesting is look, remember the cut? Remember I said one side I cut halfway through, and you remember that? And there was just a tiny sliver of bone left. Look what it looks like now, solidly healed and a very thick lamina. In fact, even thicker, just as thick as a normal. Don't you find that interesting? What it looks like? So we had this. We had a at a.
I was wondering, yeah,
I'm pretty sure there's not a posterior fusion. I don't have it. I didn't take a picture of it, but I can't access the images because otherwise I have to go out of PowerPoint. It's a mess. But just we had it once. I was at the last Academy of Orthopedic Surgeons. There was a laminoplasty meeting, and the topic was, can you let football players go back after laminoplasty? And I think you can. I mean, this has got nothing to do with this lecture, but what do you think? You think, look at that. Look how thick that thing is. Can't you? These young guys, they have these tiny spinal canals that play NFL football, and they get quadriparesis. You can't let them keep playing football like that. They'll get a spinal cord injury. It's never been done.
If you look at the natural history of Lamina Plasti, but less so than seem to produce certain disease.
Right, they progress. Yeah, we're going to get into that too, because if you do a decompression surgery, the OPLL can get worse. So this is just at C3, and just I want you to look at C3, and this is relevant. You see this black line across it? So you have the white is OPLL, and then there's a black line, and then there's another white line, and that's called a double layer sign. And this is relevant later on. So here she doesn't have it at C4, but this just shows you a couple interesting things. Is on the left is 2014, on the right is 2016, and look how it progressed at C2, C3, and there's like a double layer. There's a black line through all that OPLL at C2, C3, and she's gotten a lot worse. And just the axial cuts, the foramen stenotic at C6, C7, and she has triceps pain. So I think there's a very good chance that may be all that's bothering her, really. I mean, that could be the source of all of her symptoms. C5, C6 had a foramenotomy last time, if you remember, and it still looks open and normal. C4, C5 looks great. C3, C4 looks great. But C2, C3 again has pressure on the spinal cord, and the lamina is intact from the progression of the OPLL. So any questions so far about this case, about the recurrence? Left triceps. So it's a 49-year-old woman now with left triceps pain. So I just want to go over just a couple more things, and you guys can interrupt me. What usually causes cervical stenosis? So the first one on the left is just protruding discs and protruding osteophytes directly, which is just like typical spondylosis. The B is spondylolisthesis, that can compress the spinal cord. Kyphosis can compress the spinal cord. And OPLL, the last one on the right, can compress the spinal cord. And OPLL can be continuous, it can be segmental, mixed, it can be sessile, and it can be pedunculated too. I've seen both. So this is usually, we use these for tumors in the GI tract, but on the left is pedunculated, and on the right is sessile. You can get both in OPLL. I've seen both. And there have been, this is just a couple articles I read that are recent about revision surgery for laminoplasty. This was an article of 913 patients that had laminoplasty in Japan, and 34 were revised. And they broke them into late and early, and they broke it up by 2 years. If they're revised within 2 years, it's early, less is late. And where was the OPLL in these cases? Usually C4, C5, C6 are the typical, which is usually where we get cervical degenerative disc disease. And why did they progress? Why did they go back to surgery? Residual stenosis early, but the delayed cases, the 10 were progression of the OPLL. So if they had to go back to surgery 2 years later, it was because the OPLL progressed. And the typical surgery that they did was an anterior approach to remove the OPLL from an anterior approach. And usually when you do that, it has to be a corpectomy. So these are just a couple cases that the OPLL came back and then they went anterior and did a corpectomy. So the OPLL, does it grow? The answer is the typical growth is 0.3 to 1 millimeter a year. But 1 millimeter a year is a lot because you only have 10 millimeters. So with 10 years, there's no spinal canal left. So it's a serious problem. We just say, so this is another article that Rue put out in 2009 at WashU. He did 130 laminoplasties, and most of the early laminoplasties were from his technique where he used an anchor suture, which the laminoplasties closed down, but the plates are a lot better than the anchor sutures. And in his cases, 5 were for kyphosis. He only had 12 revisions out of 130 cases, 9% revision rate, 5 spondylolisthesis. 8 of the cases, or 6%, were progression of the OPLL. I won't get into that. So this is another interesting article from the Journal of Neurosurgery in 2005 that's very relevant in this case. Is if you go through the front of the neck to take out the OPLL, which is the best way to remove it all, are you going to get a spinal fluid leak? Because what happens is the dura ossifies. And this is a case in Japan where they looked at all their anterior cases, 111, 18 cases, and then when they got spinal fluid leaks, basically the dura was ossified, you assume, and it wasn't iatrogenic. They looked back on those cases and they said, can we predict whose dura is ossified? And they felt the top right, these are 3 different causes of ossification of the dura. The top right, they called it a double layer sign. So if you see a double layer sign, if you see ossification, then lucency, and then another ossification, they found, I think it was 9 out of the 11 cases of double layer signs, they had a spinal fluid leak. So if you see that, there's a very, very high chance that dura is ossified. So what happens is you go through the front of the neck, you remove all the OPLL, and all of a sudden you got this huge spinal fluid leak from a huge dural defect, which is a big problem. I mean, it's fixable, but it's not something you want to do. So these are the other 2 things. You can also have isolated, and you can have like these en bloc ossification. So this is just the isolated. This is the double layer sign, case of double layer sign, and this is the en bloc. And the key is there's like a beak on the sagittal cut. So the double layer sign is a very high chance that you'll get a spinal fluid leak. So this is our case. She's got a double layer sign at C3. So the other thing is doing a corpectomy at C3 is not easy because what happens is the mandible gets in the way. So it's really hard to do. It's doable, but you kind of have to pick your battles in life sometimes. I mean, it's very risky. The other thing you can do anteriorly is what's called the anterior floating decompression method. This is the normal way you remove something from the front. You peel it off the dura. But anterior floating decompression method is you thin the OPLL all the way down to 5 millimeters, and then you basically, on the very edges of the OPLL, you just make a border where it's just floating. The thing's just floating, and it can float anteriorly, so you don't have to remove it. So that's what the Japanese do in these cases to decompress OPLL anteriorly. You need 20 millimeters transversely during the corpectomy. You have to thin it down to 5 millimeters, and you need a margin of 2 or 3 millimeters. I mean, I've only done this once, and I wasn't planning on doing it, but I realized like this thing is not coming off the dura, so I just left it there and just exposed it, and then what happens is it's just sitting there floating. The other interesting article I found from Japan is they looked at people who progressed, and they found the factor that was the most significant was range of motion. So not age. Age was a factor, like who progressed. The younger people progressed, but what was the highest correlation for progression was range of motion of the neck. So in my small mind, I think if you fuse someone, it will stop the progression of the OPLL. And I just go back to orthopedics. When you fuse a joint, that thing never gets a disease again. Like when you fuse a subtalar joint or any joint, the disease process stops. In fact, everything sort of remodels and shrinks. What are your thoughts about? Now, there's no literature about that fusing for OPLL. Does it stop the progression of the disease? What do you think of that, Charlie?
Well, you know, if you enter the approach, it's fusions, already, I don't usually see patients get stenosis in that same level. I think one or two patients, elderly men, who had interbody fusion, who had excellent decompression now, and come back later. They do have some bone back into the spinal.
After you fuse it?
After, but not a lot. Never to the point where I sort of even.
Well, yeah, that's an interesting topic though. But if you incompletely decompress somebody and fuse it, if there's a fusion at the level of stenosis, people don't get symptoms. I think there's fewer symptoms.
Yes, I mean, in fact, Henry Bowman used to show
He would say they remodel. He always says,
and they have so much
right. So that's what's in my mind for this woman now. Like, so what? Okay, so that's some interesting. So discussion now. What do we do with this woman? She's 47. She's 49. She has left posterior arm pain. She's got this big OPLL pushing on a spinal cord at C2, which is a bad place. Should we do a laminectomy? That's it. Should we do a laminectomy infusion? Should we do an anterior decompression? I mean, that will take it out, and then you don't have to worry about it ever again. But again, she's got a double layer sign, and it's hard to get up to C2. Very difficult because of the mandible gets in the way. Should you remove the plates? Should you do a foraminotomy, C6, C7? I mean, I asked before I did the surgery, I asked 5 surgeons, and of course, whenever you ask advice 5 people, you get 5 answers, different answers, and they're all different and they're all conflicting. Should you fuse the whole thing from C2 to T2? Just remove everything and end of story, so she'll never have another problem? What do you do with her?
going to the front, with her, I mean, as he's saying, it's very hard to get to that. And plus, in cases where I've done from the front, I really felt like they had to do a very extensive decompression and get to the all boundaries of the skin before you start taking it out.
Right, just like a tumor. You have to get all the way around it before you take it out.
So usually it's a much bigger section, much more than you would for just a large fish. It's so much bigger. And 2 3, reconstructing that would be
It would be a circumferential deal. You'd have to put something in the front that's suboptimal and then go posterior, right? This is pre-op. This is pre-op.
Yeah.
Mm.
And that's going to
Yeah, to span it.
Yeah.
So some two surgeons that I respect said just do C2 to T2 fusion, remove everything. So you never have to worry about anything ever again. Is that what you do?
Basically. Take off the lamina. The question is, are you going to change part of the experts? So is that in reality, that
Right, you're gonna get occipital C1, C2 instability. Right, that's the problem. But you don't have a choice. I mean, this is a bad problem here. Okay, so any other questions about or comments so far? Okay, so this is what I did. I just did a C2, C3 full laminectomy. I removed the plates and I fused C2, C3. And then I just did a foraminotomy left C6, C7. I did not fuse from C2 to T2 just because I felt it wasn't necessary. It's less surgery for her. I'm also, my personality is I stage things. I do the least amount that I think is going to work as long as I feel like there's a low probability she's going to come back. And I thought I definitely needed to fuse her because we got to somehow stop the progression of this disease at C2, C3. It's at a very bad place for her. So I just put PARS screws at C2, lateral mass screws at C3. The exposure was actually very easy. I mean, I was surprised. The surgery took 3.5 hours and didn't lose much blood. Here's the lateral mass screws and a PARS screw at C2, C3. And you can see one plate still there. And post-op, I got an MRI just to evaluate the cord. And because I wasn't very happy with the alignment with the spinal cord because you can see the lamina's gone, but you can see it's the spinal cord still draped over this mass, but there's more room. Here's just another MRI. Actually, this is the MRI before on the left and after on the right. You can see if you look up at the top, C2's gone. Here, C2's gone. And so the spinal cord, because there's no lordosis, the spinal cord cannot drape backwards. But I think the spinal cord does have more room. Here's hold on. Here's pre-op and post. It says post-op on the left and pre-op on the right. So there's more room for the spinal cord. Here's just shows the lateral mass screws at C2, and you can see on the right, the C2 lamina has been totally removed, so there's plenty of room behind that OPLL. And this just shows my foraminotomy on the left. Left C6 frame, and you can actually, it's kind of funny, you can see the two little screws from the laminoplasty plate that I removed. I had to take the plate out to do the foraminotomy, the C2, C3 screws, and these are just the PARS screws that I put at C2. I don't know. I don't put in C2 pedicles screws because it's got to be a perfect shot. I mean, look at where that screw has to go. I mean, you have to avoid the spinal canal, and you have to avoid the vertebral artery. It's got to be perfect. So I was like, this is like, I mean, why do that? Why not just put in a PAR screw? So you don't even, or if you put in a 12 or 14 millimeter screw, there's no chance you'll get the vertebral artery. You just put it straight in. I mean, maybe it's not as strong as the pedicle screw, but I think it's logical to put in a PAR screw at C2. You can put it in, yeah, you can put a lamina, but then you got that weird angulation. So here's the lateral mass screws, and this is just the only plate that's left. And you can see at C6 now, it just doesn't even have a plate. It's just sitting out there because I had to remove it for the foraminotomy. So, so that's it. So we did I did the second surgery, and the patient's completely asymptomatic now. 2 weeks out, she gave me a big hug. She's fine. So the question in my mind now is C2, C3, is that thing going to push further into her spinal cord? And will she progress? Or am I right about the fusion? By fusing her, she's not going to progress anymore. She's going to stop. And interestingly, intraoperatively, despite all that OPLL at C2, C3, she moved a lot. Like when I put a pin through 4 interfacet and moved it, there was a lot of motion there. So this is not stiff. That OPLL does not cause stiffness. There's a lot of motion. So I think by fusing OPLL, it'll stop the progression of the disease. I don't know. I don't know if that's true or not, but I think it is. What are your thoughts about that?
really a posterior procedure, whether it's it can be a spurt in growth of that. But with the fusion, it's
But that doesn't make any sense to me. Why would OPLL progress from laminectomy? I think it's because there's more motion.
maybe more motion, but also more blood supply. And that's the thing induce more blood supply. Healing process. I don't think that, I think, you know, some just watch it and see what happens. I haven't seen, but I think I see more remodeling as opposed to
I've never seen OPLL remodel, but I don't care if it does. I just don't want it to get worse.
you know.
It's C2 for this woman. Okay.
So you're thinking that because
Yes.
we see a lot of segments of OPLL. I would think that most people in that segment.
Just telling you they did. I tested on purpose on her. I was curious. Right. Well, I think it depends on the type. If you've got OPLL that totally bridges the disc space, there's going to be no motion. It's a fusion basically. But she's not. She's mixed. See how she had the double layer sign? So there's motion there. So it's an unusual. There's just it's not organized ossification. It's just unorganized and there's motion. Yeah, I don't know what the answer is.
The follow-up is just based on symptoms. She feels good, you're good to go.
No. I'm gonna get a CAT scan on her in a year.
Okay.
I'm not gonna just go on symptoms because, like I said, like myelopathy. What I'm gonna have like a healthy 50-year-old woman just say, "Oh, now my legs don't work." Well, it's kind of too late now. It's like, you know, the horse is out of the barn. Now she's myelopathic, which is not good. I mean, people want to have normal use of their arms and legs. So if you wait until that happens, then it's sort of too late. So I don't want to wait. I don't want to wait for that. Well, what do you think about that? I mean, I don't want to wait till someone becomes myelopathic. Someone like her, she'll know because I taught her tests to test herself every month if she's getting it. So like we said, the grip and release sign, walking, the ability to walk a heel to a straight line. She's testing. I told her to keep testing yourself to see if you're becoming myelopathic. And very often people can tell that like something's weird's going on. I can tell. I've seen that happen before. So I watch cervical stenosis patients. And if it's an intelligent person that will work with you, I think they can tell. So no, she's not 290. She's like 190. No. 200 pounds? She's 200 pounds. Not really. Not really. She's not. 300 pounds would be hard. 200 is not too bad. What else? Any other questions about OPLL? We'll go once we're done. I'll shut this down. We'll look at it. You think she's fused from C3 to C6? Oh, so a continuous OPLL, and now C2, C3 is basically the first mobile level of fusion. Yeah, that's a good. Actually, it probably is true. Probably.
But I don't think anybody would say that he would definitely do something like that.
Well, C3, C4 looks fused for sure. And C5, C6 is fused for sure. Right? C6, C7 looks fused there. Yeah, you're probably right. Actually, it looks fused on both sides, C6, C7 there. So she's probably, maybe she's just moving at C2, C3, and C4, C5. And you're probably right.
Three, four, four, five on the back, 5, 6, maybe not.
Wait, 5, 6 is fused. This thing's fused.
Oh, yes, yes.
C4, C5 is probably not fused. C3, C4 is fused. The C6, C7 we said is fused.
Right.
So I think I think we don't have to look. I think you're right. So that's another reason why I don't have to do a C2 to C7, C2 to T2 fusion. She's already fused.
Well, just think
C7, T1.
but
Yeah, I'd rather just deal with that when it happens.
If that happened at T7, T1, do you then start at the top and go all the way? Or do you just treat C7 to T2?
I would think you need to do one or two
Yeah.
C6 to T2. Yeah, I'll do C6 to T2, and then I'll put a plug in the front too. I'll do circumferential. I usually like that's what I usually do for cervical thoracic junction. Right. Any other questions about OPLL? Okay. Thanks for coming. See you guys next month.
Thank you.
Welcome.